Hello, good morning, everyone. Hello, my champions preparing for the part 2 exam and also for the part 3 exam. So based on your request, I'm recording this video. This is to discuss the cervical cancer in pregnancy. Of course, this is one of the two articles published in April 2020. So this took article start with cervical cancer is the commonest gynecological malignancy diagnosed in pregnancy, which make a possibility of a single best answer question. Okay, so that's very important. Okay, to take care of the epidemiological facts in the part 2 and part 1 exam. Then, what is the problem actually of the cervical cancer in pregnancy? The problem is that the symptoms of the cervical cancer, early symptoms, can mimic those of complication of pregnancy. Okay, that's why there is a delay in diagnosis. What are the symptoms? Like, for example, the patient had some postcoital bleeding. Okay, the patient have some bloody discharge, or even pain if it is more extensive. So anybody will think that this is just a complication of pregnancy. Okay, that's put an emphasis on the examination are necessary. Okay, and from the cervical screening, if you remember, the routine screening is not advised in pregnancy. We can defer the routine screening, but if there is any high risk, like for example, a patient that had her smear before the pregnancy, and then she got herself pregnant by the time the result came out, and this necessitates a colposcopic examination, then it must be done. Why? Because we cannot compromise the safety of the patient by delaying necessary investigation to rule out or to diagnose cancer, right? So this is very important. Okay, so what is the staging investigation that we will use for the staging process, and what is the treatment? This is the aim of this article. Okay, so let's see. In the introduction, as I told you, we know that from the epidemiological point of view, the commonest gynecological malignancy diagnosed in pregnancy, and the incidence is still very low. It's rare, 0.1 to 12 per 10,000 pregnancy. Okay, and the presenting symptoms. So how the woman will present to us with the cervical cancer in pregnancy. Early stage could be asymptomatic and only detected by the smear. But if there is any symptoms, though, we see that the symptoms in pregnancy, like bleeding, as I told you, painless vaginal bleeding, pelvic or lower back pain, or even urinary frequency. This can resemble the common condition related to the pregnancy. Okay, so also other symptoms such as dyspareunia, postcoital bleeding, abnormal appearance even of the cervix by examination. So this can cause these symptoms. Other symptoms for advanced disease like hematuria, like urinary incontinence, like lower limb edema, or change of the bladder or bowel habits. Okay, so red flag signs that you need to explore is like loss of appetite, loss of weight, or fatigue. So those are important things that to ask about in evaluation of the woman. Okay, so if the woman presented to you and you have examined her and you visualize the cervix and you find that there is any abnormality, so what is the action to be taken? If there is any abnormality by examination, you need to refer this woman to an experienced colposcopy. Okay, I'm sorry, I'm receiving some messages. Or gynecology under the 2 weeks rule. And the 2 weeks rule, if you are familiar with that, that's mean the urgent pathway. Cervical screening in pregnancy, Okay, this is a revision of what we said. So the cervical screening of the pregnancy say that the routine recall and test of cure symptoms in pregnancy can be deferred until 3 months after delivery. Pregnancy itself is not a contraindication to a smear test for women who require follow-up after treatment of cervical neoplasm, CGIN, or cervical epithelial neoplasia, CIN 2 or 3, with involved or uncertain margin. Cytology should not be delayed until after pregnancy. So as we agree, high-risk lesion, those lesions should be investigated properly, and pregnancy should not be, a cause when you neglect such patient. Okay, so that's very important. How about the colposcopy and the excisional biopsy in pregnancy? Colposcopy is safe during pregnancy. Okay, so the examination itself with the magnified lens is safe. The aim of the colposcopy, where possible, is to exclude invasive disease and to defer biopsy until after the woman has delivered. Colposcopic assessment during pregnancy require high degree of skill and should be undertaken by an experienced colposcopist. The physiological effect of pregnancy can make it more challenging to accurately assess the cervix. Okay, that's why you need an expert to do this colposcopic examination. Okay, so the factors that make it this challenging, like the cervical mucus, cervical hyperemia, eversion of the columnar epithelium. Anyway, you understand that the colposcopy will be challenging in here, so you need the expert to do it. Okay, so if invasive disease is suspected at the colposcopy, what are you going to do? Very important to take a biopsy. Okay, so if you have invasive disease picture at the colposcopic examination, you must take biopsy. So is it safe to take biopsy? It should be done. It must be done. Okay. So it's important to understand that the punch biopsy diagnosing CIN cannot reliably exclude invasion, but there is risk of hemorrhage with diathermy loop is approximately 25%. So the risk of hemorrhage, if you are using the diathermy loop, okay, is 25%. So such biopsies should be only undertaken in clinics or operating theater where appropriate facilities to manage hemorrhage are available. Okay, so biopsy is a must. Okay, and there is a limitation if you use the punch biopsy at the beginning for the confirmation that it might not exclude the invasion. If you use the Litz biopsy or the cone biopsy, okay, so you need to understand that the diathermy loop hemorrhage risk is 25%. Okay, staging of the cervical cancer. So the staging of the cervical cancer will be done, okay, by assessing the invasion to the vagina, parametrium, or even the uterosacral ligament at the first site of the spread. Also, bladder and rectum and pelvic and para-aortic lymph node may also be involved. Okay, so now I have a pregnant woman. What is the staging follow-up? This is the most important question you need to ask yourself here. Okay, so MRI, in this case, pelvic magnetic resonance, will be the first line of staging in cervical cancer in pregnancy. Okay, so I need to do staging. What is the image modality? It's MRI. Okay, so it is safe in pregnancy at any gestation. There is no ionizing radiation. Therefore, if distant metastases are suspected, then assessment by abdominal MRI can be considered. Okay, so what is the difference between a woman with cervical cancer with no pregnancy and the pregnant woman with cervical cancer? The difference is that we used to do the pelvic MRI, okay, but for the abdomen in the non-pregnant woman, we will do the CT. But here, okay, you can't perform abdominal CT in pregnancy. So if you would start image modality, okay, I would start with MRI. For even investigation for the abdominal extension or assessment, I will go also for abdominal MRI. Okay, so abdominal MRI assessment can be considered. Okay, so of course there will be challenges in the interpretation of this MRI because of the pregnancy. Okay, like for example, you will see dilated veins. Okay, also reduction of the image quality by the fetal movement. But anyway, this is what we are allowed to do during the pregnancy. We don't need to use contrast, okay, in the investigation in pregnancy. And you should remember that the gadolinium and iodine-based contrast medium can corrode the placenta and can be excreted into the amniotic fluid from the fetus, okay? And there is no evidence of teratogenicity or adverse fetal effect, but it's better to avoid unless it's absolutely necessary. The CT scan are usually contraindicated during pregnancy, of course. Okay, this is a fact. However, CT can be considered as second choice for the MRI. Okay, so when the need to fully stage the patient. For example, if there is high suspicion of lung or pleural spread. So this is a case with distant metastasis. This is advanced case. Okay, so risk outweigh the benefit, okay, or benefit outweigh the risk, then you have to take the decision based on that, okay, whether the CT can be used or not, but this is only for the advanced stage. The box, and you understand, guys, that the boxes are so important. The box in here, just revising the 2018 FIGO staging of carcinoma of the cervix, starting by the stage 1 and its subdivision 1A and 1B. And in 1A, we can see 1A1 and 1A2. 1A1, invasive carcinoma that can be diagnosed by only microscopy with maximum depth of invasion less than 5. And please take care here, he speaks only about the depths of invasion. 1A1, major stromal invasion less than 3 millimeter in depth. In 1A2, major stromal invasion 3 or more and less than 5. So it's actually 3 or 4 millimeter in depth. For the stage 1B, then we see that the invasive carcinoma with major deepest invasion, 5 or more millimeter, greater than the stage 1A, limited to the cervix uteri. Here started the rule of the dimension. So he said 1B1 invasive carcinoma, 5 millimeter or more of stromal invasion and less than 2 cm in the greatest dimension. So simply, I have a case with depth of stromal invasion 5 millimeter. Okay, so 5 millimeter, this way, that's mean 1B. Okay, so 1B, if I told you that the greatest dimension is 1 cm, so now you understand that this is 1B1. If I told you that still depth of invasion is 5, but the dimension is more than 2 cm. Okay, so now more than 2 cm could be, for example, 3 cm. Okay, 3 cm means 1B2. If it is more than 4, then the stage is 1B3. Again, more than 4 in the dimension. Okay, more than 4 in the dimension. This is the 1B3 staging. And this stage of particular importance, and I will comment on that in the treatment and management. Let's see the stage 2. The stage 2, now the carcinoma invades, but beyond the uterus, okay? Remember, stage 1, the carcinoma can be diagnosed, okay, either by the microscopy or by colposcopic examination, but it's confined to the cervix uteri, okay? From stage 2, we are outside the uterus, okay? So for the stage 2, the carcinoma invade beyond the uterus, but has not extended into the lower 1/3 of the vagina to the pelvic wall. 2-1 involvement limited to the upper third of the vagina. without parametrial invasion, 2B with parametrial invasion, but not to the pelvic sidewall. In stage 3, the carcinoma involves the lower third of the vagina and extend to the pelvic wall, and or the causes hydronephrosis or non-functioning kidney by the pressure symptoms, and involve the pelvic and or the para-aortic lymph nodes. For stage 4, the carcinoma has extended beyond the true pelvis. Okay, and this is involved the mucosa of the bladder, rectum. Okay, so for example, distant metastasis, distant organs. Once we are outside the true pelvis, then that's mean we are in stage 4. I'm sure that you, my friend, know very well the updated cervical cancer, okay, since in the 2019, at the late 2019 and 2020, the college have revised or had agreed the staging of cancer 2018 from the FIGO. So radiograph, can I do X-ray in pregnancy? Yeah, I can do. Why not? Okay, so X-ray to the chest is safe during the pregnancy. Laparoscopic lymphadenectomy and sentinel lymph node biopsy. Okay, so accurate nodal staging is essential for the prognosis and the treatment of cervical cancer. Okay, so what can I do? I can do for the stage 1 disease, for example, laparoscopic lymphadenectomy. Okay, that's to allow risk stratification. Okay, so that's very important. Assessment of the lymph node. Why? Because I'll tell you guys, presence or absence of lymph node metastasis is going to affect the decision of management and whether to continue with this pregnancy or not. That's why it's very important in the first trimester. They said that beyond the 22 weeks of gestation, the nodal resection is not recommended owing to the insufficient number of nodes retrieved and also the size of the gravida uterus and overall risk of the surgery. Okay, so let's see the treatment. Okay, so the treatment, yeah, before the treatment, there is a role of the ultrasound. Yes, okay, the ultrasound is for the assessment of maternal hydronephrosis. Okay, and of course, the ultrasound has no limitation in pregnancy. Let's go to the treatment. So treatment of the cervical cancer in pregnancy, treatment of stage 1A1 without lymphovascular space invasion. Very important to understand that if there is lymph node invasion or not, that will affect the overall risk. So most of the stage 1A cancers are diagnosed after excisional treatment. So diagnosis is unlikely to be made during pregnancy, provided that there is no lymphovascular space invasion. Stage 1A1 cancer may be treated with cone biopsy. Okay, so you can offer this as a treatment for stage 1A1 diagnosed in pregnancy. Yes, why not? Okay, so for example, again, the woman had her colposcopic examination for a suspicious cervix or for a high-grade CIN 2 or 3. Then the result came, the histopathology result came at this is microscopic non-invasive carcinoma of the cervix. So what is the management? Now she become pregnant. Okay, can I plan for a cone biopsy? Yes, I can do. Okay, and the British Society of Gynecological Cancer also say that cone biopsy can be done. Lids in pregnancy can be done, provided that it's taken as one piece, okay, and that had all the margin, the safety margin, okay? So once you achieve the safety margin and you have the specimen in one piece, then it's fine. That's why here they said may be treated by cone biopsy. Anyway, you have the option of cone biopsy is correct. You have the option of the lids, but provided that it should be in one piece, the specimen complete and with good safety margin, then it's fine. The optimum gestation for this treatment is between 14 and 20 weeks. That's very important. So the depth of invasion and margin can be more accurately assessed from a single specimen with minimal heat artifact. Okay, so this is why they would accept or they would prefer cold cone biopsy over than the loop, the heated loop. So therefore, a knife or laser cone is advocated by some for this treatment, okay? If the margin is positive, then a second treatment should be considered. Women should be encouraged and supported to aim for vaginal birth if there are no obstetric contraindication. So for the 1A1, I can perform cone biopsy, okay? I even can, because you will read it in other guideline, I can perform the LETS, but provided that it's the specimen is not shattered, okay? It's in one piece and the safety margin is complete. If the margin is still positive, second treatment can be considered. Yes, second re-excision can be considered. Women should be encouraged and supported to aim for vaginal birth if there are no obstetric contraindication. The risk of the pelvic lymph node and metastasis in stage 1A1, as you know, is less than 1% or even 1% at its maximum, okay? And the risk increased to 3 to 6% for stage 1A2. That's why the lymph node removal in stage 1A1 is not, necessary in all cases. The involvement of a specialist gynecological pathology review will increase the detection of the lymph vascular invasion and the tumor volume. This may be beneficial in determining the need for pelvic lymph node dissection in early stage disease. So that will depend, the lymph node dissection will depend on positive lymph vascular invasion or not. Okay. Treatment of stage 1A1 with lymph vascular invasion or stage 1A2 or 1B1. Okay, so now we have left the low risk patient with lymph vascular invasion 1% or even less. And now we are with a patient, even 1A1, but there is positive lymph vascular invasion, or stage 1A2 with risk of lymph node invasion 3 to 6%, or 1B1. Okay, so the gold standard is radical hysterectomy and bilateral salpingectomy. With or without bilateral oophorectomy, that will depend on the future fertility wishes. With bilateral pelvic lymphadenectomy. So the pelvic lymphadenectomy here is a must. Okay, why? Because the risk of lymph vascular invasion is high, is getting increased with the staging. Oophorectomy or not, that will depend on the fertility wishes, but basically radical hysterectomy, bilateral salpingectomy, plus bilateral lymphadenectomy, plus or minus oophorectomy. Clear, guys? So I have a pregnant woman and she is diagnosed with 1A1, okay, with positive lymph nodes or positive lymph vascular invasion. What is the management? The standard management, gold standard management is she will continue the pregnancy, okay? The standard management is radical hysterectomy, okay? So cesarean section with planned the radical hysterectomy, bilateral salpingectomy, with or without bilateral oophorectomy. And don't forget the lymphadenectomy should be done. Okay, so the woman should be fully counseled because the situation is very, sensitive, because that will depend on her decision whether she would like to continue the pregnancy or not to continue the pregnancy. This is very important. Okay, so extensive discussion, MDT, okay, to decide what to be done. If the woman is under 22 weeks of gestation, and we can do a staging lymphadenectomy, why not? Okay. If there is pelvic lymph node dissection is positive, then termination of pregnancy could be considered. Okay, let's say no, she doesn't want to terminate this pregnancy. She is like 16 weeks pregnant, and we have performed the staging lymphadenectomy for her. And the dissection or the histopathology came to confirm that this is positive lymph nodes, dissection. We discussed with her the termination, but she is not willing to do that. She wants to continue with the pregnancy. So if she wants to continue with the pregnancy, there is any alternative, or we just leave her without treatment? No, there is an alternative. What is the alternative? Okay, for the woman who wish to continue the pregnancy, the neoadjuvant chemotherapy may help to treat the disease. Okay, but this is only after completion of the first trimester. Okay, so neoadjuvant chemotherapy can be done in pregnancy, yes, after the first trimester. Okay, so this is the suggested treatment for a woman refused to carry on surgery, the hysterectomy, okay, and she wants to continue with the pregnancy. What is the alternative to surgery? Neoadjuvant chemotherapy. Neoadjuvant chemotherapy. What is the precaution? This is very important, okay, for your exam. So not in the first trimester, and we will come in this article to discussion of what are the precautions or care that we will advise for a woman receive neoadjuvant chemotherapy. Okay, so only after completion of the first trimester, if the lymph nodes are negative, then a trachelectomy or delay in treatment until after delivery can be discussed. Okay, so if a trachelectomy can be done, then this is something can be discussed with the woman. However, there is a high risk of bleeding and miscarriage. It's important to acknowledge the risk associated with the trachelectomy requiring appropriate patient counseling and MDT discussion. So now you have, and this is for our friend part 3, because there was a similar case before in the exam, even before release of this article, because management of cervical cancer in pregnancy is super important topic. So now I have a lady with cervical cancer in pregnancy more than stage A1, A1, and for example, A12 or 1A2. So this case, I want to discuss with her the termination of pregnancy. No, she doesn't want. Okay, so what's the local treatment I can offer her? There is a trachelectomy or there is neoadjuvant chemotherapy to discuss with her. The patient should have the decision after discussion with the MDT. The MDT also is going to help her by assessing the whole situation and the personal risk of the woman. Okay, and they will give her the advice and option. Okay, so it should be fully discussed and extensively discussed with the woman, the risk and the benefit of each option between the neoadjuvant chemotherapy or the trachelectomy. This is along with the MDT, right? So this is for the woman, okay, who came in the before 22 weeks. After the 22 weeks of gestation, okay, then the treatment will include the neoadjuvant chemotherapy with alternative option of delaying treatment until delivery, okay, because local treatment here will be very risky. Okay, so how about the trachelectomy and cervical circulage? You know that trachelectomy was a very good option for the woman who is not pregnant and she had early stage cervical cancer more than 1A1, and she is willing to complete her family before the decision of hysterectomy. So trachelectomy, you used to do it, and there is a separate article for the trachelectomy. I need you guys to revise this one. It's so important as well. So simple trachelectomy is a surgery to remove the cervix. This, compared with radical procedure, involve removal of the cervix, parametrium, and upper vagina, okay? So the radical trachelectomy is different from simple trachelectomy. What is the difference? In the radical trachelectomy, we remove the cervix, okay, with extension removal or extensive removal of the normal tissue. That include parametrium and upper vagina, okay? When a gynecological oncologist is undertaking a vaginal, laparoscopic, or robotic radical trachelectomy, cervical circulage is routinely performed as part of the procedure. Okay, of course. Women who have undergone an antenatal trachelectomy at high risk, 20 to 30% of preterm delivery. Recent systematic review recommend the serial ultrasound scan to monitor for ischemic shortening or funneling. Okay, so guys, the circulage is there already. Okay, this is a part of the procedure. So please, if he give you a pregnant woman with trachelectomy, what is the next step? Next step is not cervical circulage. Cervical circulage should be done, okay, as part of the procedure. Next step is the serial ultrasound scan to monitor the isthmus shortening or funneling. However, it's important to acknowledge the practical difficulties of performing such a scan and the paucity of evidence in this area. Fortnightly urine and genital screening has been recommended from 16 weeks of gestation with consideration of prophylactic antibiotic. Steroid injection for the fetal lung maturation should be discussed at the 24 weeks of gestation because the very high risk of preterm labor, of course, with the theoretical advice of limited activity in the second half of pregnancy, minimizing strain on the circulage, along with avoid 6, of course, from the 20 weeks. Overall, there is mounting evidence that radical trachelectomies result in higher rate of obstetric and surgical complication and should not be undertaken during pregnancy, okay? So the radical trachelectomy for a woman who is diagnosed with cervical cancer prior to pregnancy, early stage cervical cancer, and she wants to complete her family, okay? So the advice is please keep, okay, the option of radical trachelectomy in your mind for the pre-pregnancies, okay? And this is different from simple trachelectomy. This being said, that the 2020 British Gynecological Cancer Society guidance on cervical cancer in pregnancy discourage performing even simple trachelectomy during pregnancy. Okay, once again, this is a consequences of blood loss and poor fetal outcome associated with such procedure. Okay, so after he give you here in the article, okay, after he give you the options to do the trachelectomy or not, okay, and this should be appropriate patient counseling and the MDT, then he comes and he discussed the risk of the trachelectomy and the recommendation of the British Society of Gynecological Cancer, okay, in her cervical cancer guidance, the 2020, and this is our main source, of course, of study of cervical cancer, that discourage the trachelectomy due to the high blood loss and poor fetal outcomes, okay? So if you ask me about the decision, are you going to offer the trachelectomy for the patient? Theoretically, it's an option. Practically, it's not advised, okay? And what is the supporting evidence? This is from the British Gynecological Cancer Society. Okay, so that's why I told you guys before I discuss this part, this is for the part 3 exam discussion mainly, because in the part 3 discussion exam, you can explain, okay, the pros and cons of every option. So you show the examiner that you know, okay, and you complete the answer by mentioning the limitation and risk, okay? I hope that this is clear. Stage 1B2, less than 22 weeks of gestation. In this scenario, large loop excision of the transformation zone lids or radical trachelectomy may not be an effective treatment option because of the size of the tumor. For women who wish to continue with the pregnancy, the neoadjuvant chemotherapy may help to shrink and manage the disease. Also, only after completion of the first trimester. If she opts for the termination, then radical hysterectomy and pelvic lymphadenectomy can be performed with the fetus in situ. Okay, so this is another question about management of the 1P2 for the gestation less than 22. So we will go for radical hysterectomy and pelvic lymphadenectomy if the patient choose to terminate, okay, with the fetus inside. We will not do a hysterotomy because chances of survival of the fetus is very low, of course. Stage 1B2, more than 22 weeks of gestation. For the stage 1P2, more than 22, now there is chances of survival. So consideration should be given to allow time for the fetal maturation. The chemotherapy will help provide this opportunity. Delivery should be by cesarean section in appropriate gestation. Once the baby has been safely delivered, radical hysterectomy and pelvic lymph node dissection should be undertaken. If the woman chooses not to undergo chemotherapy while she is pregnant, an observational approach can be employed until pregnancy, when surgical treatment can be undertaken simultaneously. Okay, so more than 22 of the gestation, give time, or we can consider giving time for the baby to maturate, okay? And then we plan for the delivery in appropriate time with the cesarean section followed by the radical hysterectomy and pelvic lymph node dissection. Stage 1B3, and I think that this is one of the cases that came in part 2 exam. For women with cervical cancer at stage 1B3 and above, neoadjuvant chemotherapy can help manage this disease. However, its efficacy has been investigated in only a few trials, and further research is warranted. The role of staging lymphadenectomy is controversial even, and follow-up without neoadjuvant chemotherapy is not recommended because it's likely to compromise the pregnancy. Once fetal maturation is achieved, delivery by lower cesarean section should be followed by either surgery or radical chemoradiation, depend on the initial stage and response to the chemotherapy treatment. Women with advanced metastatic disease have a poor prognosis. The intention of treatment at this stage will be palliative only, with the aim of controlling the disease rather than cure. Okay, so we will go for the summary of the treatment, but after we comment on the chemotherapy. The chemotherapy is contraindicated in the first trimester because it interferes with the organogenesis and has been associated with risk of 10 to 20% of major malformation. This is about the chemotherapy. So this is a figure, but let's continue chemotherapy comment and then go. So treatment after 14 weeks of gestation is considered safe, with a fetal malformation rate comparable to general population. So from 14 weeks, it is safe to offer the chemotherapy. Okay, yes, it's safe. No significant long-term effect to the fetus have been noted from the use of the chemotherapy after 14 weeks. However, it's important to acknowledge that there is no large trial of chemotherapy in pregnancy. In this situation, correct dating of the pregnancy is essential. The platinum agent, which agent I will use, okay? So, you know, the platinum agent like the cisplatin and the carboplatin, taxane group also like the paclitaxel have been proved to be effective in cervical cancer. The regimen of the carboplatin and paclitaxel is favored over the cisplatin and paclitaxel because it's better tolerated and less nephrotoxicity and ototoxicity. Carboplatin and paclitaxel can be given as weekly or 3-weekly regimen. An advantage of the 3-weekly regimen is that allow for the closer patient monitoring. Where necessary, this enables the chemotherapy and antiemetic dose adjustment. Close collaboration with between the oncology and obstetric team is required. The timing of cesarean section is important to ensure that the patient is not neutropenic. So very neutropenic. So very important to check for the neutropenia before the delivery. Okay, so 3 weeks gap between the final dose of the chemotherapy and cesarean section is recommended. This is very important. So if you are planning for cesarean section at 34 weeks, for example, okay, and your patient has been diagnosed at 32, will you start the chemotherapy? No, there's no rule here, okay, because you have to stop the chemotherapy 3 weeks before the cesarean section. That's to allow the maternal and fetal bone marrow to recover. Chemotherapy is not recommended beyond the 35 weeks of gestation to reduce the risk of spontaneous labor occurring when a patient might be a neutropenic. So here in the box number 2 summarize the recommendation for systemic treatment and supportive medication. This is the box number 2. Recommendation for systemic treatment and supportive medication for patients undergoing cancer treatment in pregnancy. So, number 1, dosing of the chemotherapy drug during pregnancy should be based on actual weight. Okay. The same dose per meter square or dose kg square should be used in non-pregnant patients. So we are using the same dose for the non-pregnant. Chemotherapy is contraindicated in the first trimester of gestation to avoid interference with organogenesis, and you would remember that the risk was 10 to 20% of malformation. Fetal benefit of treatment delay should be balanced against the maternal risk. After 14 weeks, administration of several anti-cancer drugs is feasible, including taxanes, platinum agent, anthracycline, okay, and the bleomycin. Chemotherapy is not recommended beyond the 35 weeks of gestation. It's important to give 3 weeks window between the last cycle of chemotherapy and the delivery to allow both mother and fetal bone marrow to recover. Until safety data is available, target therapy should be avoided during pregnancy. Metachloropramine, okay, or the 5-HT3 antagonist, ranitidine, proton pump inhibitor, prednisolone, or hydrocortisone can be used if necessary. So let's see colposcopy, clinical examination, MRI, or ultrasonography, biopsy, and or flat conization is being done, and you have now estimate of the accurate staging. What is your management? Let's say for the stage 1A2 or 1B1. And please note that 1A1 is not included here because the treatment is local treatment, right? Okay. So here, 1A2 or 1B1, if the patient is less than 22 weeks and there is lymph nodes, then advised termination. Okay? If there is positive pelvic lymph nodes, then advised termination. If the patient is more than 22 weeks and you remember that assessment of lymph nodes here, okay, is not the main factor of the management. Okay, we can allow time for maturation of the fetus. So we discuss with her either the neoadjuvant chemotherapy or the termination. Okay. This is the management for patient more than 22 weeks of gestation with A12 or 1B1 state. For the patient with 1B2, okay, so we have 1B2, but less than 22 weeks of gestation. Now, you know, my friends, that we always look for early stages for the pelvic lymph node. If the pelvic lymph nodes are positive, then please terminate. Okay. So if there is no involvement of the pelvic lymph node, then we can consider either the chemotherapy or the termination based on the patient wishes. Okay. Delayed treatment after delivery, or neoadjuvant chemotherapy, or if this is according to the patient wishes. So in the more than 22 weeks of gestation, we advise either the chemotherapy or to delay the treatment after delivery, or some patient will choose to terminate as they know the diagnosis. Okay, so will be only based on the patient wishes. But in the flow chart, they give you the choices between the neoadjuvant chemotherapy or to choose to delay treatment after delivery. 1B3, look to the gestational age. Again, if the gestational age is less than 22, then discuss chemotherapy, but please remember that this should be only after first trimester, after 14 weeks, or termination of pregnancy direct away. If the patient is more than 22, then again, the same options, chemotherapy or delay the treatment after delivery. Why here he didn't mention something about the pelvic lymph node invasion? Because this is 1B3, okay? So we know that there is a very high chances, okay, that pelvic lymph node is involved. We don't need even assessment to tell us that. Okay, guys, so what I need you to do is please revise the important pathways of management. After you listen to this video, I doubt that you need to go and read all the details, especially before exam, but I need you to understand the principles of management. So investigations are safe in pregnancy, and colposcopy is safe for assessment. MRI for the staging. Ultrasound will help you to explore if the kidney involved or there is hydronephrosis or not. You can take biopsy or flat conization also to confirm your diagnosis before you decide to start treatment or to terminate for this patient. After you get the staging, you look to the which stage is it, okay, and what is the gestational age, possibility of the lymph node being positive. Once the lymph node is positive, we advise actually termination, especially if we are in the gestational age below 22 weeks. So it's like a rule, below 22 weeks, positive lymph nodes, advise termination. Okay, more than 22 weeks, there is a chances of survival of the baby. So we can give neoadjuvant chemotherapy. Some patient will advise or will choose to take the treatment or to delay the treatment until the delivery. So this will be up to the patient. In the cases, okay, that your friend posted in the group, and they said that they had a question of 32 weeks or 31 weeks, okay, and she is diagnosed with cervical cancer 1B3, okay? So what is the management in this case? Guys, the advice is to terminate or to end this pregnancy by the 34 weeks of gestation by cesarean section. And once the baby is delivered, then we will do the total hysterectomy, and we will do the lymphadenectomy and so and so. Okay, so in this case, there is no rule to give the chemotherapy because your surgery should be after 2 weeks. Okay, so I will advise to deliver and then start the treatment after delivery. Thank you very much, guys. I hope that this summary of discussion is helpful. Okay, and good luck in your exam.